Hi, I'm Dr. Hal Seiden. I'm a pediatrician at BC Children's Hospital, and I'm also the medical director of Canuck Place Children's Hospice. I practice pediatric palliative care and also pediatric pain medicine. I'm here today to talk about the use of high-dose opiates in palliative care. And one thing people have to remember about palliative care is in this situation our goal becomes comfort, not resuscitation. So what is the role of high-dose opiates? High-dose opiates have been the mainstay in palliative care to treat advanced pain for many, many years. And I always think of this as a three-part analogy, which is I think you have to have both the brains to do this, the heart to do this, and the courage to do this. And the brains part is really knowing the dose, and one can look that up. That's not difficult. And the heart part comes with the idea that we're really trying to provide comfort to these children, and our goals of care are oriented towards that. And the last part is, as I say, is the courage or the guts or whatever it takes to really do what needs to be done to make that happen. I think in the emergency room this requires a significant shift because our goal is no longer resuscitation, but really one of maximizing comfort. So how does one do this? Well, we know that there's no upper limit to the dose of opiates. The problem I often see is that people are very cautious about getting to that no upper limit phase. I think that for the person who's doing this without a lot of training, it's always safe to start low and go slow. There's no harm to that. But then knowing how to increase with each dose until you meet where the pain is. So, for example, we would say that if one dose is not effective and it's been given intravenously, then somewhere in the next 15 minutes you're going to see the effect. And if it's not helping at that point, you need to go up by 50 to 100% of the previous dose and do this cumulatively. So, for example, if you're starting at 5 milligrams, your next dose might be 7.5 or 10 milligrams, and the dose after that might be as high as 20 milligrams, and you just keep going. The other point that's worth knowing is that there's evidence that apneas and respiratory depression in the kind of setting where a patient's in severe pain is very, very uncommon. Stimulation of the sympathetic nervous system in the hypermetabolic state that many of these patients are in seems to be very protective against apnea and respiratory depression. And of course, one may experience apnea or respiratory depression, which can be very hard to distinguish from the end-of-life phase of a child or a patient versus the actual drug effect. When your goal is to treat the symptoms, then you have to accept that respiratory depression may be a component of that and that this is part of the trajectory. What to do when the dose gets high enough that you think that the pain is turning the corner is that's when you stop, because your drug level will still be rising. This does not mean you've gotten absolute control of the pain. It simply means that you see some easing of the pain, and at that point you back off and hold your next dose. I think that kind of sequence should give you enough time to begin initiating therapy and at the same time get in touch with an expert to get further consultation advice. So I hope this tip is helpful for you in your practice in the emergency department.